Hi, this is Mrs. Condry. This is Preop Care for NUR 1213. Welcome to our first class. Our objectives today is that you will be able to identify key assessments and interventions for each phase. So this is for pre-op period. And we'll explain the rationale for the interventions during this phase, and we'll outline advantages and disadvantages associated with outpatient surgery. So the purpose of surgery is for diagnosis, of course. Many times patients will get an x-ray and they discover that there's maybe something wrong. So they go in and explore. And it's for cure, so maybe they've had a biopsy and they've discovered it is cancer, so they're going to take out a tumor. Palliative, if the patient has, again, a cancer and a tumor's pressing on an area so they can take out that tumor. It can be preventative. Say they have a gastric bypass due to severe obesity. That bypass can be to prevent further problems from obesity. Exploration, it could be that the patient has had abdominal surgery several times and then they have pain. It could be that they have adhesions that have grown, so they may have to go in and explore and find out. And then it could be cosmetic. It could be a nose job, a boob job, all that kind of stuff. There are many surgical settings. It can be elective surgery, it can be emergency surgery. It can be inpatient or outpatient. It can be done at a doctor's office, an ambulatory care center. It can be done in the hospital, and there are freestanding surgical clinics. The advantages of outpatient surgery is that many times there are fewer lab tests, less costs, fewer pre-op and post-op medications, and decreased risk for infection since the patient goes home. There are many bugs hanging out in the hospital. The disadvantages are that if there are any problems, the patient has to go by ambulance to the hospital. If the patient codes, it's less likely that the staff will be trained to care for that. So the pre-op interview can be done in advance or on the day of surgery. Many times the hospital staff or the surgical center calls the patient to ask that. Also, sometimes they are done, the interview is just done by computer. So the client goes on the computer and answers all these questions. And then the staff the next day during the surgery will review it. It can help the staff identify risk factors such as COPD, diabetes, any chronic diseases. And it helps the staff to plan for care and for teaching. So maybe the patient is mentally disabled, so they may need extra special care. They can also have some pre-op teaching there before the surgery. And so subjective data is that we're going to assess their psychosocial status and their coping skills, their past medical history, of course allergies, medications, and we're going to review any disease processes they have of their body systems. And we're going to make sure the patient's NPO for usually 6 hours for adults. For kids, it's different. It's 2 hours for clear liquids, 4 hours if it's an infant with breast milk, and 6 hours if it's formula or food. This also is important to know that the patient's not allowed to have cough drops or any kind of lozenge or gum, because that can increase the gastric acid, and so that's not allowed as well. So that's important to teach families and patients, because their procedure can actually get canceled because they come in chewing gum. Objective data, the Joint Commission requires all patients going to the OR to have a documented history and physical by a licensed medical provider. It can be from a nurse practitioner or a PA. A nurse will complete a physical assessment, and labs will be required depending on how old the patient is. If it's a woman, they may need a pregnancy test. A diabetic will need a finger stick. Patient on Coumadin will need to have an INR, and of course the Coumadin will need to be held for a certain number of days prior to the procedure. And then diagnostic testing will need to be done, such as an x-ray of a fracture, an ultrasound of, say, an ovary that needs to be removed that has cysts. Nursing management of pre-op teaching is we need to verify informed consent. We can witness the signature, but the doctor is ultimately responsible to say that the patient understands the risk. So when we witness a consent, it's not saying that we are verifying that the patient understands the risks and benefits. We're just verifying that the patient is signing. The surgeon needs to mark the site of surgery. Say if it's a left arm fracture, they need to mark the left side. It just depends on what it is. If it's a heart catheterization, the doctor doesn't mark it because they may need to change sites anyway. We need to check the armband, verify the name, date of birth, remove all the valuables if they're going into the OR, and complete an OR checklist. We need to give pre-op medications that the physician orders, and we review all the paperwork and have the patient buoyed prior to the OR. So the key assessments are, we need to assess medical history. Allergies are important because if the patient's allergic to cefazolin, and the doctor often orders that particular antibiotic, we don't want to cause a problem. We want to assure also that the patient has taken certain medications prior to the procedure, depending on what the physician has ordered. Beta blockers are now something that the Joint Commission recommends that the patient take a beta blocker if they're on one prior to the OR, and then often NPO for all the other meds. We need to make sure they're NPO. We need to make sure that their H&P is done, that the certain labs and diagnostic testing is on the chart, their armband is correct, their pre-op meds are given, and everything is complete. The advantages of outpatient is less costly, less risk for infection, but the disadvantage is if there are any problems, the patient has to go to the hospital. And that's it for pre-op.